Hi everyone. I wanted to do a PowerPoint voiceover for some of the things that we probably won't have time to go over in lecture. Your lecture is roughly 2 hours long, and it's for 2 days, and you already know the lecture calendar that there's 2 days worth of GI and a lot to cover. So I thought I'd take some of the smaller disease processes and kind of make mini video PowerPoint voiceovers for you guys. And you've already had me for a couple weeks now, so you kind of already know how I teach and how I think. So I figured, like I said, these are things that we probably won't go over in class, but at least you can still get some sort of lecture out of it. So anyway, so here we go. The first one is actually going to be Gerd. This is gastroesophageal reflux disease. It's the backflow of gastric or duodenal contents into the esophagus. Essentially, your patient has too much acid in their stomach for a million different reasons, and it's the sphincter itself is not completely closing enough to keep that contents or that acid down. I call it vapors. Essentially, there's too much acid in their stomach, and with that comes these vapors that are kind of coming up through the sphincter and to the esophagus, and actually causes that burning sensation. And let's see here. As far as assessment-wise, they're going to have what they complain of being heartburn, epigastric pain. There'll be dyspepsia, regurgitation, difficult or painful swallowing, and hypersalivation. I may have mentioned this in my other PowerPoint voiceover, but I recently, over the last year, have been diagnosed with Gerd, and I actually had all this stuff, and essentially, Gerd is a lot of teaching for your patient. You're teaching them what not to eat, what to eat, when, what time not to eat, or what medications they can actually take to help with Gerd. And like I said, it's a lot of education. It's a lot of stuff. I mean, this is one of those disease processes that can actually be cured. Based on what they eat, when they eat, what medication they can actually take, and this can actually go away. But again, I was diagnosed with Gerd about a year ago. I actually was able to take Zyrtec or Zantac, which was over the counter. But of course, they took it off the shelf because it was causing, or what they believed had too many carcinogens in it, so they just took it off the shelf. I got lucky enough to go to Costco about a month before they took it off the shelf and buy what I believed would be what I normally would buy. And of course, Costco, you buy thousands of everything. And so I actually had enough to last me for a very long time until my primary care physician, had not really so much found out, but I had mentioned it, and they said, let's actually really put you on something a little better controlled, like Protonics. And we'll cover that as we go over the meds. But essentially, I was having the heartburn. I definitely had the regurgitation at night. I really would wake up in the middle of the night from sleeping on my back, actually choking, and not really knowing why I was choking, and not really even knowing why I was waking up with a scratchy throat. But essentially, it was the contents and the acid actually coming up through my esophagus and causing that burning sensation. And again, it would really get to the point where it was in the back of my throat. And that was actually what was causing the choking and the scratchiness. I also would wake up with a very, very dry mouth and also a pretty bad taste. But I've had it for so long that I never kind of really thought about what it was like not to have it until I started taking Protonics, and then it actually went away and realized, wow, I really was waking up with a pretty bad taste in my mouth and pretty scratchy throat. Often enough that like I said, I thought it was really more of a sinus problem or maybe some drainage, but really it was actually the stuff coming up in my stomach. So as far as interventions, again, this is really just more, teaching your patient what they should and shouldn't do and when they should be doing it. They should be avoiding foods that cause esophageal irritation. Peppermint, chocolate, coffee, and alcohol, fatty foods, and cigarette smoking. These things actually is what causes the sphincter itself between the stomach and the esophagus not to fully close. And based on that, your patient's actually causing their own problems. And again, we're Americans. Throw a pill at me and I'll just, I'll be better without really stopping and stop doing what I was doing to actually cause the problem in the first place. The fatty foods, I mean, that's really more because of the fact that you're causing more irritation to the stomach itself, which causes more acid, and in turn, that's what causes the acid to build up, and again, the vapors to start coming up through that sphincter into their esophagus. Your patient should be eating low-fat foods, high in fiber. Avoid eating or drinking 2 hours before bed. This gives the stomach enough time for it to actually build up enough acid to break all that food down and for it to be digested and for it to go away. Your stomach has a natural pH balance, if you want to call it that, to where, again, the acid increases in order to break down the food, and then once that food has gone away and is no longer needed, then the acid amount in the stomach goes down. So it's there for a reason, but again, if you teach them what foods to avoid, like spicy foods, and again, you're going to find out a lot about my poor dietary habits over the next week, but I love ice cream, and my favorite is like Reese cups, and I love dark chocolate. So between the dark chocolate, the coffee drinking, the fatty foods, the spicy foods, I mean, these are things that I'm really doing pretty much late in the evening, and I definitely eat a pint of ice cream almost every night before I even go to bed. So I think the acid reflux has always been there. Again, I was always able to take some sort of Zantac or something over the counter that would actually take care of it. And again, I really just kind of lived with it and took care of my own symptoms, but I never really changed my diet. So avoid eating before you actually go to bed. That keeps the acid in your stomach to be at a low level, so it's not causing more problems. You can also elevate the bed. I slept on 3 pillows at night, and most of it was because I thought it was more of a sinus issue, but it really wasn't. It was really more of the acid reflux. They want to avoid NSAIDs. NSAIDs will definitely cause some irritation to the stomach, which in turn is not going to help either with the acid reflux, or later on we'll talk about peptic ulcers, and that will cause some problems there too. Take antacids, H2 receptor antagonists, and proton pump inhibitors. We'll talk about those as far as when we get closer, further into the meds. And then there is a possibility that an intervention could be surgery. I did have an EGD this last summer just to make sure that I didn't have what they call Barrett's. What that means is basically I had, acid reflux or Gerd for so long that not only does it actually cause irritation to the lining of the esophagus, but it also can chemically change the lining of the esophagus itself and cause some cancer cells. So they did some biopsies and made sure that that wasn't the case, and it wasn't. And definitely the Protonics is helping. Did I change my diet? Not really. But I know that I'm able to take Protonics every night before I go to bed, and it really lasts for a 24-hour long period, and it seems to be helping with all my problems. So here we go with the antacids. Antacids work by counteracting or neutralizing the acid in your stomach. They do this because the chemicals in acids are bases, which are the opposite of acids. So essentially, you're taking antacids to actually lower that acid in your stomach. Last week, you guys did the case studies. I know that you did the one with the guy who was the construction worker. And, basically, again, he was a smoker, he was a drinker, he was eating the foods, he was, taking NSAIDs. I mean, he pretty much was the perfect storm for somebody to actually have some sort of gastroesophageal reflux disease. He was taking antacids either preventatively, knowing that, hey, if I eat this hot dog in the middle of the afternoon or the spicy taco or whatever, he knew what it was going to do to his stomach. So a lot of times your patients will take antacids, whether it's Tums, whether it's Rolaids, whether it's some sort of over-the-counter meprazole. There's a million different meds that are out there over the counter, and a lot of times these patients will actually take them knowing that it's going to cause it's going to fix the problem, knowing that when they have dinner or lunch, it's going to be a problem. So, which is okay. The problem they're running into is that you want your patients to take their, whether it's antacids, H2 inhibitors, or proton pump inhibitors, you want them taking those at least an hour before they eat or 2 hours after they eat. And the reason why we want them to do that is because you're eating, the acid in your stomach increases, it breaks down the food, and it digests and moves stuff along. It's meant to do that. So if you're taking something that actually reduces the acid before you even get the food, then you're really kind of counteracting what it's really supposed to do. So digestion may be slower because there isn't enough acid. There's also acids that have magnesium-containing acids. One thing I want you to know about as far as your antacids is that Tums being more calcium-based, I think of calcium beginning with a C, causing constipation. So the biggest problem your patients could face by taking a lot of Tums is it could cause constipation, which in turn causes another problem. So now they're actually going to take some sort of stool softener, not knowing that it's really the antacid that's actually causing the problem. Now, magnesium-based antacids do the complete opposite. They actually cause diarrhea. So, it's one of those things where, again, you're not just taking care of grandma or grandpa or your uncle or aunt or cousin or somebody who actually has acid reflux, but you're taking care of that problem. But then there's so many other factors that go along with it. Grandma should be taking, an acid that is full of calcium like Tums, because grandma actually is, brittle and frail, and she probably is at an age where she can get all the calcium that she possibly can consume and absorb, so that she actually has strong bones. So in case when she does fall down and break a hip, that it's not going to be so bad, or it'll actually heal better, or she at least can bounce back from a little bit better. So, but on the flip side, your patients that, especially renal patients, you don't want them taking meds that are high in electrolytes, because their kidneys can't actually get rid of what they don't need. So, again, your end-stage renal patient, they're going to Walgreens and picking up milk of magnesia for and acid and Gerd and reflux, but in turn what they're doing is they're actually increasing the magnesium level, and they can't do anything with that. So now they're causing dysrhythmias and other problems. So again, when you do study your antacids, really find out what are they made of, what are they really meant to do, how long do they really last for, and why are they taking them at a certain time, and we'll get more into that when we get into like the protonics and the other meds. So we have the histamine or H2 antagonists. We have the Femotidine or the Retinitine. These H2 antagonists, these are more of a every 12-hour med. Now, it doesn't make any sense that your patient would take a 12-hour med as opposed to Protonics or Omeprazole, which is a 24-hour med. But you have to remember, go back to your block 1 and block 2 stuff. When you do medications and when your doctors prescribe medications to their patients, it's go low, go slow. So if the Femotidine or the Retinitine actually works, and it works for a 12-hour period, and they don't need to take it twice a day, and it works just as well, then start with that. I will also tell you too that I want you to think about when the patient actually takes this. Do they take it at 8 o'clock in the morning and it lasts all day long, which is great. It's 12 hours. It's already covering breakfast, lunch, and dinner. Or is your patient actually having okay day, or not having really so much the GERD problems during the day, but more of a nighttime problem by eating and laying down? At that point, they're able to take the med before they go to bed, and it lasts them all night, and it will decrease the regurgitation, and decrease the acid in their stomach, so they're not waking up choking, or they're not gagging on that reflux that's coming back up, so, or having that throat irritation. So it's really just a matter of what works for them and when. And now, as far as the proton and pump inhibitors, you have the Omeprazole, you have the Prevacid, the Nexium, the Protonics. I take Protonics at night because if I take it at night, then it doesn't screw with my meds that I take first thing in the morning. The biggest one is my Synthroid. So you have to remember that if you're taking an antacid, whether it's a proton pump inhibitor or a H2 inhibitor, then, when are they taking it and what are they taking it with? Because if it reduces the acid in their stomach, it might actually reduce the effectiveness of the other drugs that they're taking. So that's why I take my Protonix at night, because I can take it at night. It lasts for 24 hours. I know that probably around 9 o'clock at night before I really go to bed, I can tell that it's starting to wear off a little bit. But I take it within about an hour or so. It actually goes away, and I feel better. And I also sleep better, and I actually don't have any problems. So, but if I took it in the morning, then I have to wait an hour after I actually take it to take my Synthroid and my other meds. And if I also want to eat breakfast, then I have to also wait after that. And then I also have to remember not to take the, antacid and eat at the same time, because then it slows the digestion. And so it just snowballs into a whole bunch of problems. So for me, if I just take it before I go to bed, it works all night. I'm able to wake up, I feel good. I'm able to take all my other meds, wait about an hour, then have my breakfast, and then it doesn't really seem to bother anything or my stomach. So, all right, so as far as diagnostic testing, they will definitely do an EGD on your patient, whether it's, mine wasn't emergent, so I didn't need to be tested, as soon as possible, but they knew that at some point I was going to have an EGD just to really go down and make sure that, do I have an ulcer? Is the acid reflux causing any esophageal problems or esophageal ulcers, or some sort of corrosion where it's actually causing the problem? So the EGD, again, I think this picture looks more like they went up your nose, down your throat. That's possible. For me, they actually put a bite block in my mouth and basically laid me on my side, gave me some propofol. I fell asleep within about a second, and they went in orally down my throat into my stomach, and they actually can go all the way into the small intestine. They'll do biopsies as they go down. They may, check and see if, maybe there might be a little bit of red spots, maybe there is an ulcer or some bleeding. They didn't find anything on mine, which was a good thing. But it also allowed me to know, and for them, my GI doc, to know that, okay, here's a baseline. Here's the starting point. 46 years old, had EGD in 2020. There weren't any problems. I'd been put on some NSAIDs for some other disease processes, and the NSAIDs, at least now we know at this date and time, they're not causing any problems. So when I am 50 and I do have another EGD just to make sure that the NSAIDs aren't causing any issues, then I'm okay. This is more of a either rule out to make sure that there is no problem, or also to make sure that there's a baseline and there is no problem, or if there is, at least they know, size, shape, things like that, as far as where it is and whether or not it could go away, or if it will stay or get bigger. All right, so as far as education, again, this is a disease process that, again, if I ate what I was supposed to, stayed away from the things that actually caused the GERD in the first place, I really could come off the Protonix. But I'm a typical American, and I like to eat what I want, when I want, and I drink a lot of soda, as you probably all have seen in my virtual lectures. But I don't drink the soda for the actual caffeine. I drink it more for the carbonation, because I can only talk for so long until my throat starts to get a little dry and stuff. But I do like my soda. I used to be able to drink about a 6-pack, and was probably creeping into a 12-pack every day or so. I've now limited it to at least drinking either one Pepsi or one Sprite, and 1 cup of coffee, and then the rest of the day I have to actually drink water. So I've kind of, spread it out so that way I'm able to get some sort of release, or at least some sort of comfort, and I've done a little bit better with that. Not really so much a peppermint person, but I definitely like my chocolate. I love my dark chocolate. The darker the better. So I like that. And again, if I'm either eating it before I go to bed, or if I'm eating it in my ice cream, I'm definitely consuming it somehow. Coffee. Not a huge coffee drinker, but I definitely have one at least in the morning. But I can really drink one and be okay with the rest of the day of not having one. It's probably more of a social thing than anything else. But in the same sense, now that we have a COVID and I'm sitting at home, at a desk staring at you guys for 4 or 5 hours, I'm really I'm good with drinking one, and being good for the rest of the day. I'm not a big alcohol drinker. I never was. I'm not really against it. It just wasn't for me. So I don't really have a problem with that. Fatty fried foods. I wouldn't really say that I'm really fatty and fried. It's probably more spicy and really just not great and healthy for me. And other than that, everything else seems to be okay. So I think, like I said, if I really changed my diet, a little bit better, and like I said, consumed more water and less soda. The carbonation is probably really what's doing it, and the caffeine isn't helping. So as far as a low-fat, high-fiber diet, based on my cholesterol, it's not necessarily low-fat. As far as high-fiber, yeah, that's probably not high-fiber either. We're eating and drinking 2 hours before bed. I have done better. I started eating dinner earlier in the afternoon or evening, and that way I'm able to consume my pint of ice cream every night, but at least I'm kind of eating it earlier in the evening, so that way I'm not actually going to bed on a full stomach and a stomach full of junk food. Elevate the head of the bed 6 to 8 inches. That actually has gotten better. I don't think I really need to sleep on that many pillows. Now it's more of a comfort, and that's what I'm used to. The NSAIDs, I do take NSAIDs for another disease process that's not major, but I do take it, and so we're really kind of watching those. And again, I do take the Protonics. I think one thing I have actually mentioned, or I think is actually on your medication sheet, is octreotide. You will have patients who will come in, not so much as far as they won't put them on a Protonics or an octreotide drip for having some sort of GERD. But your patients will actually come in, especially male patients or even female patients. Male patients, they kind of present with I've got the chest pain, it's raining down my arm, up my jaw, and that numbing diaphoretic, symptoms of having an MI. For females, because of the fact that it really could be a lot of different symptoms in presenting, they tend to be more misdiagnosed with some sort of cardiac related problems. But the reason why I bring this up is because when the patients come in with, I've been having this, chest pain for the last couple of days, they're going to run 2 different series of tests. One, they want to actually run a lot of tests to rule out that it's not a cardiac issue, but they're also going to run a lot of tests and really make sure that it is a GERD problem. One of them is actually going to come up either positive or in that direction, and that's the direction they go. If they don't and they wait around, or if they actually kind of go in the GI or the cardiac issue, cardiac direction, and your patient is getting better, it just prolongs their hospital stay. So again, it'll go in 2 different directions, trying to rule out 2 different things at the same time. Again, they're really kind of trying to rule out these different things and kind of go from there. So the whole point of the story is that if your patient comes in with GERD and cardiac symptoms like the chest pain and stuff, you're not going to put them on a Protonic drip or a octreotide drip. But if they actually come in with what would be believed as a stomach ulcer or a duodenal ulcer, they'll actually put them on Protonics and octreotide drips, because those are vasoconstricting medications, and not in a cardiac sense, but a vasoconstricting in the sense that it actually will constrict the veins small enough that it will actually have, if there is some sort of bleed, it will actually reduce it down to a point where it's so slow that it gives your body a chance to heal, or it won't necessarily heal, but the GI problem, the bleeding problem, will actually become so small that at least we're not continuously losing blood and having to actually do blood transfusions. So proton pump, Protonics and that octreotide is really meant for those 2 things. Now, as far as peptic ulcer, I have a picture here that it's a painful sore ulcer that's in the lining of the actual stomach. Your stomach, based on homeostasis, is meant to, you over time could develop an ulcer, but your body's trying to heal that as it goes. But the problem is that your stomach is constantly wet. So I use the example, and this sounds really gross, but it's almost like having your kid falls down, scrapes their knee, gets a big old scab, and then they play in the pool all summer long, and it takes forever for that scab on their knee to heal, because of the fact that, it's constantly wet. So if you let it dry out and let it alone, it will eventually heal on its own and it'll be fine. Well, your stomach's that same concept. It's just constantly wet. You're constantly adding spicy stuff to it. You're constantly adding, bad food to it. You're constantly adding acid-producing contents. So it's never really fully healing, and it just gets worse and worse. And it literally will just keep burning, because the acid is very acidic, and it just keeps burning and burning until it actually becomes an actual ulcer itself. Now, to the degree of whether or not it actually gets so big and so deep that it becomes a bleeding ulcer or not, it's really depending on how long you've actually had it, how much your body's able to heal, either some of it or part of it, and whether or not you're able to take meds to actually help reduce that. So the peptic ulcer is really just the ulcers that are there that just never really quite healed, and your patient never really did anything to actually reduce that acid and problems that were aggravating that issue. Causes, again, it's stress, which causes more acid in the stomach. Smoking will also do the same thing. Corticosteroids, NSAIDs, alcohol, a family history, and an infection like H. pylori. So there could be many factors. I really kind of listed these as probably the most common because, I mean, these are everyday people that really can have them, and not really knowing that, okay, so you have a stressful job, you've been working hard all day, you come home, and whether you're an alcoholic or you're actually just wanting to relax and just have a drink and just, get your mind off of work and relax, it's not a big deal, but that drinking causes more acid in your stomach. So, and it also causes more of an acid or not acid, but as far as an ulcer in your stomach. So, or you have patients who are, let's say they're actually having a lot of stress, and let's say that people think that smoking relaxes them and causes calms them down, when in fact it really doesn't. It's a vasoconstrictor, and it actually causes them to be ramped up even more. So a lot of these things are pretty common, and a lot of patients don't realize what it truly is doing to their actual stomach. Assessment-wise, they're going to have, as far as the gastric ulcer, a gnawing, sharp pain in the left or mid-epigastric region. It usually occurs 30 or 60 minutes after a meal. This is because of the fact that your patient, eats something or drinks something, and all of a sudden your body kicks into gear going, okay, let's produce more acid so we can actually break it down and digest it. Well, eating and 30 to 60 minutes after is when that truly starts to cause that pain. They can also have emesis in their, or bloody emesis, which is more common than melena. So if you have a patient who does have a bleeding ulcer, it will cause the upset stomach. They could also have the emesis, and because of that, they may actually have some blood in it, which tells people that they actually have a bleeding ulcer. Now, whether you've listened to this tonight or you don't listen until tomorrow, if you do have questions about what I'm about to tell you, please bring it up, so I want you to understand. You've been taught in Block 1 and Block 2 that if you have a patient who has a GI bleed and they throw up and it's actually bloody, then it's a upper GI bleed. If it's coffee ground emesis, then you know that it's a very small bleed. The blood is actually sitting there long enough that it's able to coagulate, and when they do throw up, they actually throw up, and it does look like coffee grounds. But that's actually a either old or a very small bleed to where it's actually not either active or it's just really, really super slow. Now, as far as the other end, if you have a patient who actually has a bowel movement and it's got blood in it, then it's a lower GI bleed. And if it's actually dark and tarry, then you know it's a GI bleed, but it's actually a very small bleed to a point where blood is pooling. And again, it's actually turning everything more sticky and dark because it's coagulated. What I want you to actually start to think about is for Block 3 being GI, this is where we're taking it to another level. You can have a patient who has either an upper or a lower GI bleed. Based on how fast or how slow that bleed is, doesn't tell you anymore where it's actually coming from. If you have a patient who has a gastric ulcer, an upper GI bleed, but that ulcer is bleeding fast enough that it's going from stomach to the small intestine and actually being passed into the large intestine, because again, I mean, you've by now should have been looking at your meds and realizing what those GI meds do. Miralax, laxatives, stimulants, those are meant to pull water into the intestines, and it causes your stools to be kind of liquefied, and then in your body's like, okay, I don't want this, and let's get it out. Well, it's the same thing with the GI bleed. if it's bleeding fast enough and it goes from stomach to small intestine, from small intestine to large intestine, and your stomach's like, oh, this isn't working, your intestines are like, get this out of me. Even though your patient has a bowel movement with blood in it, doesn't tell you that it came from the intestines itself. It just means that the bleeding is fast enough that it traveled through the GI tract fast enough for it to come out as still being actively bloody. And that no longer tells you whether or not it's actually upper or lower. So again, if you guys don't understand that, please let me know so I can make sure that you do understand it. That's a very large, it's something that you definitely need to know. I wouldn't necessarily that it's necessarily on the test, but it's that whole concept that I'm changing you from the way block 1 and block 2 taught you. And it's more of, not that they were wrong, it's just that they were trying to teach you the basics, and now that you have the basics, I can take you to the next level. So for your patients that actually are having emesis that has blood in it, yes, that is a upper GI bleed. But in the opposite direction, it really could come from anywhere. It's just a matter of where and how fast it's actually bleeding. Well, the duodenal ulcer, they have the burning pain in the mid-epigastric area, but it usually occurs 1.5 to 3 hours after the meal and during the night. And the reason why is because at this point, now food has actually gone from the stomach into the actual small intestines, and the acid itself is following with it. And not only is it causing an ulcer in the duodenum, but aggravating it, but also the food's also still being digested and still flowing through. And because it's still moving, then the pain has moved. So for a gastric ulcer, usually it's in the stomach, 30 to 60 minutes. For duodenal, it's now moved into the small intestines where food is actually absorbed and digested as far as the nutrients. And usually it's that 1.5 to 3 hours and causing that burning, because now acid's moved, so is the food, and everything has kind of moved to an area where it's actually causing the agitation. Pain is often relieved with a digestion of food. Again, if you're having an ulcer and in the stomach and it causes the pain and now the food's gone, most likely your stomach is going to stop hurting. Same thing with the duodenal ulcer. If the food actually moved from small intestines to large intestines, then again it's actually probably going to feel better because things have actually moved out of that area. As far as the intervention wise, so this is where we actually start looking at, with whether it's ulcers, GI, or stomach wise or duodenal, the pain is going to tell you roughly where the ulcer is and why the patient's having the problem. But as far as interventions, it's going to tell you not necessarily whether or not your patient is bleeding, but they're going to tell you whether or not, if your patient has a gastric ulcer that is bleeding or a duodenal ulcer that is bleeding, it's going to start changing stuff. Your vital signs are definitely going to change. You're going to have a lower blood pressure and an increased heart rate. You may actually have some sort of lightheaded and dizziness. They may actually start looking pale. You now have a bleed somewhere, and it's not in the circulatory system of where it's supposed to be. Your body's going to, based on homeostasis, start to try to fix that as best as it possibly can. Whether it's vasoconstriction, allowing the blood pressure to go up and the heart rate to actually be able to pump efficiently the blood where it needs to go. It might start shunting blood where it doesn't need to go necessarily based on how bad the bleeding is. You want to teach your patient, have small, frequent, bland meals. Stay away from the sodas, stay away from the coffee, stay away from the alcohol, stay away from the smoking, stay away from the spicy stuff. I mean, you really want to start, having bland meals and stop producing so much acid so the ulcer has a chance to heal, whether it is in their stomach or in the duodenum. Administer H2 receptor antagonists or PPIs. Again, this is to actually, reduce the acid in their stomach, so it reduces the amount of acid that's actually causing that ulcer to either begin with or allow it to get some sort of time to actually heal. Administer antacids, neutralize gastric secretions, administer a mucosal barrier. I definitely need you guys to actually know saccharifate. Saccharifate is a medication that actually lines, I call it a Band-Aid. Again, you have your little, kid with a scraped up knee that's wet all summer long from being in the pool. Saccharifate is the same concept. It actually takes that Band-Aid, goes straight to the ulcer itself, covers the ulcer as a Band-Aid, and it actually gives a protective coating so that way the acid isn't causing that ulcer irritation. Your patient will take a breakfast, lunch, and dinner. Usually it's about an hour beforehand. Again, it's meant to actually cause a Band-Aid over an ulcer and for it to actually heal. So when you are eating, then it produces more acid, that it at least has some sort of barrier for it. I definitely want you guys to understand prostaglandins, and it's in your book, so definitely look it up and try to see how that actually works. Patient education, again, peptic ulcers and GERD, upper GI problems, those are usually things that actually can go away and be fixed. It's really just a matter of your patient taking the time to change their diet, change their lifestyle, change their, whether it's their eating habits or the time they actually eat, what they're actually eating, and again, actually taking a regimen of medications and making sure that they actually work. So avoid consuming spicy foods, avoid smoking, avoid your NSAIDs, sleep well, avoid stress. Basically really just living a normal, healthy life. Now, if you have a family history, I can see that you can probably be more apt to getting one, whether it's GERD or a peptic ulcer or a duodenal ulcer, but that doesn't mean that you have to have one. So it's just a matter of you actually trying to deal with how to reduce the acid in your stomach, try to deal with eating a better healthy diet, and trying to avoid all these things, which will help in turn get rid of the problem. All right, so I think that was a quick 35-minute down and dirty of GERD and upper GI as far as ulcer and duodenal. So if you do have any questions, let me know. Definitely send me emails, or I can definitely do Skype. Again, this is really just more of we probably will not go over in class, but again, I think that if you really stick to your assessment, what am I actually seeing in patients who have GERD? This is definitely a disease process that can be cured. So what do I actually teach my patients so it keeps them out of the hospital? What do I teach my patients so that it keeps them off the needing PPIs or H2 antagonists? What can I do to get them to be better at home and healthier so that way this doesn't cause other issues, especially a GI ulcer, whether it's peptic or duodenal? And again, that's you have to remember, when it comes to diagnostics for any GI problem, I can't see that stuff at the doorway. So we're having to use diagnostic studies to help me take care of my patient. So whether it's an EGD, my patient presents with GERD and I know what those symptoms are, I could probably figure out that that's what it is, but I also need EGD to actually truly confirm that I'm right, and I'm actually going down the right path. Think about, when you think about GI, it has to be, internal, and a lot of testing and stuff will actually help with that. So, all right. So if you have any questions, let me know.